Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with leukemia, lymphoma, and multiple myeloma? Find out more right now. My guest this evening is Dr. Kieron Dunleavy with the Hematology Oncology Division at Georgetown Medical Center. Kieron, welcome to Housecall.
Thank you. I'm very happy to be here.
Great. So briefly tell our viewers about your professional background.
Sure. Yeah. So currently I'm the director of blood cancers at Georgetown, MedStar Georgetown. And I'm a professor of medicine at Georgetown University. I did my fellowship training at the National Cancer Institute many years ago. And before that, I did my medical training in Dublin, Ireland. So I came to the NCI to do my fellowship. So that's a little bit about my background.
Very nice. So the program specifically at Georgetown University, what makes it different than other programs around the country?
Yeah, so the HEMONC program at Georgetown it's an NCI comprehensive cancer center. So it's designated by the National Cancer Institute, and there are about 50 or so of those centers around the country. So that's important in terms of what we're able to do and the research that we could do and the faculty that we have. We have a very broad hematology oncology faculty with people who are specialized in specific diseases, and I oversee the hematologic malignancy division, and so we have specialists in lymphoma, leukemia, multiple myeloma, and bone marrow transplants.
How interesting. What kind of patients then are seen as part of the program?
So as part of our program specifically, we see patients with blood cancers. And we see patients who are going for bone marrow transplants, and we have a lot of new therapies, which we'll talk about a little bit, but such as CAR T cells and bispecific antibodies. So a lot of patients come to us wanting to have access to these new therapies. And we also have a lot of clinical trials. So patients will often come seeking out clinical trials with us.
So now that we've covered the types of conditions that your team diagnoses and treats, let's go on to discuss how these conditions can present.
Yeah, sure. So there are various types of blood cancers. I'll talk first about lymphoma, which is the most common one. Lymphoma is a cancer of the lymphocytes. So we have lots of different types of white cells. We have B lymphocytes and T lymphocytes. So you've probably heard of B cell lymphomas and T cell lymphomas. B cell lymphomas come from B lymphocytes, T cell lymphomas from T lymphocytes. B cell lymphomas are much more common. They make up about 85% of lymphomas, and T lymphomas make up about 15%. So that's lymphoma. And then leukemia is a cancer of the blood and the bone marrow. And again, it's a cancer of white cells. And multiple myeloma is also a cancer of white cells, but these are different cells called plasma cells. And that's a disease of the bone marrow. So these blood cancers are all very different. And even within specific areas like lymphoma, there are well over 100 different types of lymphoma. So there's a lot of complexity to these diseases.
Now, some of these blood cancers, besides having abnormal cells, also have swollen lymph nodes and an enlarged spleen. Explain to our viewers why that is.
Yeah, so we typically see that actually with lymphomas, because they are cancers of the lymphatic system. The the cell that's involved is a lymphocyte, but these cells, they gather in certain areas throughout our body. So, and we have lymphatic tissue and lymph nodes all over our body. But in some areas, if you have lymphatic swelling, it's more easy to detect. And those areas are the neck, under the arms, and in the groins. Of course, you could have enlarged lymph nodes in the abdomen or in the chest, but you will not easily know that they're there because they're not palpable. So a lot of patients, when they get a diagnosis of lymphoma, they will come with a history of having noticed a lump in their neck or a lump under their arm. That's a very common history when somebody presents with a new diagnosis of lymphoma.
One reason I wanted to interview this evening on this topic is that I know for many years, decades ago, there was almost a sense of one size fits all for treating leukemia, lymphoma, and multiple myeloma. But now there's a lot of exciting things going on, both in terms of diagnostic stratification, if you will, of patients, and how to treat patients with more specific targeted therapy. So share with our viewers how you go about diagnosing these blood cancers.
Yeah, so that's exactly right. I mean, we're really in an era of precision medicine where we have much better understanding of how these processes originate and work, and importantly, how they can be targeted with therapies. So in terms of diagnosis, the diagnosis of these different blood cancers is very, very different. If we look at lymphoma first, it is typically diagnosed by a lymph node biopsy, and we rely on the pathologist to look at the tissue under the microscope and look how the cells are lying together and what kinds of proteins they express. But the technology that we have has significantly advanced over the years, and as well as the basic pathologic diagnostic techniques like looking at morphology and immunohistochemistry. We have the ability to look at a lot of genetic markers now, and these can be very critical towards deciding on the best therapy for a patient. We also have the ability to do liquid biopsies. This is across all of the blood cancers, but particularly in leukemia and lymphoma. So we can pick up these cancers when they are present in the blood at very, very, very low levels. So this is exciting because at initial diagnosis, we can pick up these cells, but importantly, when we finish treatment and we follow patients, we have shown that we can do these liquid biopsies, and hopefully in the future they will replace scanning and other modalities that we use to stage patients. It's obviously much easier for somebody to have a blood test than to have a complicated scan.
How interesting. You mentioned earlier in your remarks genetic testing. How does genetic testing inform your diagnosis and your subsequent treatment?
Yeah, so with lymphomas, while for the most part it's straightforward for the pathologist to put them into distinct categories, sometimes it's not. And that's oftentimes when genetic testing is very helpful. Genetic testing gives you a huge amount of information. So there are many places around the country, many companies that can do very complicated genetic testing on all kinds of cancer tissues. But they can give very critical information that can inform on the optimal or the best therapy to give a patient. So for example, in aggressive lymphoma, a proportion of cases have got something called a MYC translocation and a BCL2 translocation. These are called double hit lymphomas, and genetic testing has to be done to identify that a patient has a double hit lymphoma, but the therapy is very different if that is found. Yes, that's, yeah.
Now, you've mentioned the genetic testing for the tumor, but what about the patient himself or herself in terms of what is called pharmacogenetics? Have you found that there is genetic variations between patients and how they respond to chemotherapy in general?
Yeah, so that's a really interesting area. We certainly see that. We see that if you give X drug to different patients, they will metabolize it differently, and we don't have excellent ways of accurately determining that. But we do have surrogate markers for looking at how a person metabolizes drugs. So we can look at how the white cell count responds to particular drugs, and if there's neutropenia or if there's not neutropenia, that can be a surrogate marker for some of the drugs. And actually, one type of treatment that we give a lot for aggressive lymphomas is a dose-adjusted regimen. It's called dose-adjusted EPOC, and it's a standard chemotherapy regimen, but it's dose-adjusted according to how low the white cell count and the neutrophil count goes in every individual. So each person can end up getting different dose levels of the chemotherapy because of what you said, because different people metabolize these drugs differently. And it's an area that we really need to understand a lot better, because if you have cancer and if you have a disease like lymphoma, it's highly curable. And as best we understand it, it's really critical to get drug levels above a certain threshold so that they will effectively kill the cancer cells. And if you don't get those drugs over that threshold, then of course there's a risk that you might not kill the cells. So this is something that needs to be researched much more. And so we also see that among different cultures, that there are certain enzymes and genetic characteristics that are more common, for example, in Asia, or less common in the US. So this is a really, really fascinating area, and not just for conventional chemotherapy, but also for novel agents as well. So yeah, a lot of work needs to be done in that.
Sure. And certainly, as you know, I'm a gastroenterologist, and we for many years used chemotherapy agents like 6-mercaptopurine or azathioprine. And there clearly is variations from a pharmacogenetic standpoint. So we would carefully measure certain enzymes, as you know, to see which patients were more susceptible to toxicity than others. And it helped guide our therapy. But of course, now we've embraced biologic agents and small molecules for inflammatory bowel disease. So those drugs are used less commonly. We're going to pause briefly for a public service announcement. More with my guest, Dr. Kieron Dunleavy, after the break, and we'll continue to discuss update in leukemia, lymphoma, and multiple myeloma. We'll be right back.
My baby's back from the West Coast.
Here are those pictures that you asked for your school project? First day of school, cute as a button.
So long ago.
Oh, here's Grandma Florence after that flood wiped out the whole neighborhood.
Sometimes I just cannot believe all the storms we've gone through here.
I can only hope that we'll be able to leave this house to you one day, baby. You're our legacy.
Planning for these disasters will make sure we're safe, and is the best way to protect that legacy.
Those beans smell heavenly.
Give Mom a little credit.
You know what? We should make an emergency communication plan. That way we're ready this year.
Oh,
Great idea.
At my dorm, we have emergency kits for earthquakes and wildfires, but I'm sure there's something more local I can send you with the link.
Okay,
Smart.
I'm coming to share with you guys.
Protect your legacy. Plan for natural disasters today. Visit ready.gov/plan.
We're back. My guest this evening is Dr. Kieron Dunleavy of the Georgetown Medical Center Hematology and Oncology Division. And we're discussing leukemia, lymphoma, and multiple myeloma. Kieron, when we paused for the break, we were discussing evaluation using precision medicine to diagnose lymphoma, leukemia, and multiple myeloma. Let's go on to discuss now the signs and symptoms of lymphoma. How do these patients come to your attention?
Yeah, so as I said, we have lymphatic tissue all over our body, and that really means that you can present in many different ways with lymphoma, depending on where the lymphoma is. Most people will present with an enlargement of a lymphatic gland, usually in the neck or under the arm or in the groin. But some people will present with completely different symptoms. So we have lymphatic tissue, for example, in the brain, in the bone, and in all of our different organs. So which is quite unusual when you have a presentation which is happening because somebody has extranodal lymphoma, you can have very different types of presentations. A proportion of people will have what are called B symptoms, and these are fevers, night sweats, weight loss of more than 10%. It's unusual to have these, but they're classically associated with lymphomas, and they're usually seen when the lymphoma is more aggressive. So these are some of the ways that lymphoma can present, but as I said, it can really present in many different ways depending on where the lymphoma is located in the body.
Now, you've mentioned different types of lymphoma. Where does Hodgkin's lymphoma fit into this hierarchy?
Yeah, so that's it's rarer than non-Hodgkin lymphoma, and it actually has what is called a bimodal peak distribution. So you see this disease occur in young adults with a peak age of about 20, but you also see it occur in older people with a peak age of about 70. And the two forms of the disease that are seen in younger people or older people are quite different. Usually when younger people present with this, they have disease in their chest. About 80% of them do. They tend to be female. They're usually between the ages of 15 and 35. When older people present with this, they have a subtype of the disease, which is called mixed cellularity subtype, and really is a lot different to the type that presents in younger people. But the good news is that whether it presents in younger people or in older people, the therapy for Hodgkin lymphoma is very successful with a very high cure rate. And there's been a lot of press about this recently because there have been some new therapies that have been developed for patients who are newly diagnosed with Hodgkin lymphoma that have been very successful. So the therapy for this type of lymphoma is excellent and continues to improve.
Very encouraging. So now that you've diagnosed a lymphoma and then subcategorized it through all the testing you've mentioned, what are the different treatment options for patients for different types of lymphoma?
So when you have well over 100 different types of diseases with different therapies and different approaches, you really have a laundry list of therapies. Just in terms of first principles, lymphomas can be divided into the indolent ones, or the slow-growing ones, and the aggressive ones. Most of the time, if you have a diagnosis of indolent lymphoma, you don't need immediate treatment. So we describe this as a watch and wait approach. And for a lot of people who get a diagnosis of indolent lymphoma, they can be managed with a watch and wait approach without needing any therapy for many years or decades sometimes. It's very different if you have an aggressive lymphoma. Aggressive lymphomas need to be treated as quickly as possible. And generally, when people present with those, they tend to be sick. So they notice that there are lumps increasing at a fast rate, or they have these B symptoms. So it is usually pretty evident that somebody presenting with aggressive lymphoma needs treatment as soon as possible. And then the types of treatments, are changing all the time. In terms of aggressive lymphoma, it has traditionally been treated with chemotherapy and a drug called rituximab. So we call this immunochemotherapy. And that's typically what's done in the front line. But we have a lot of new drugs. Over the past few years, I think there have been over 20 new agents approved by the FDA for lymphoma. So the therapy is changing at a very fast rate. We're doing a lot of research to try to identify what are the best treatments for people when they're newly diagnosed with this. And importantly, we can identify some people who we know from the very beginning are not going to do as well as most people. And one of the main areas of unmet need is trying to figure out how should those patients be treated. We know they don't do as well with standard treatment, so what do they need? Do they need some of these newer therapies like CAR T cells or bispecific antibodies when they're newly diagnosed? Should they be incorporated into their treatment plan? These are all really important questions, and there are clinical trials that are ongoing to try to answer those.
Now, certainly it's exciting that besides the original chemotherapy, you have, apart from that, the immune modulation therapy as well. But is there still a role for radiation therapy and or splenectomy in these patients?
Yes, so there still is a role for radiation therapy. I think it's fair to say that the role of radiation in newly diagnosed patients is certainly not as big as it was 20 years ago or 30 years ago. One of the problems or the challenges with radiation is that it can cause secondary side effects. You can see a high rate of secondary tumors and heart disease in people, especially who get radiation to the mediastinum. So if we can avoid radiation, we do, but there are rare situations in the upfront setting where radiation can be helpful and is used. And there are very important situations where you treat a patient with certain types of aggressive lymphoma and it doesn't completely go away. And in those cases, radiation can be curative. So it certainly has a role, but is not as widely used, especially in newly diagnosed patients, as it used to be. Mm-hmm. And then splenectomy is not widely used. It again is used in rare circumstances. There is a disease, for example, called splenic marginal zone lymphoma. Very occasionally, splenectomy is done for these patients, and there can be rare situations where somebody has a very, very enlarged spleen, and they end up having bleeding from it, or they have trauma, or there can be rare situations where splenectomy is done, but it's not widely done like it used to be in the past.
Let's go on to discuss leukemia. You've mentioned the many manifestations of lymphoma. Are there any differences with how leukemia presents?
Yeah, I mean, so there are, again, kind of like indolent lymphomas and aggressive lymphomas, there are chronic leukemias and acute leukemias. Acute leukemias present in a very aggressive way. So when people have a new diagnosis of acute leukemia, they tend to get sick very, very quickly, often within a few days. So it's very typical for someone who has a new diagnosis of leukemia to be totally well a week before the diagnosis, and then they come into the ER with 3 or 4 day history of bruising and not feeling well, and maybe noticing some bleeding, and their blood counts are checked, and they're very abnormal, indicating that they have a process like leukemia going on. So those are the acute leukemias. The chronic leukemias present in a very different way. There's a type of leukemia called chronic lymphocytic leukemia, which is extremely common. And as we get older, this type of leukemia increases, like most of these diseases. But if you look at people over the age of 70 or over the age of 80, a significant proportion of people will have evidence of chronic lymphocytic leukemia or CLL. That's very different to the acute leukemias, and they're managed in a very different way, where acute leukemias need very aggressive chemotherapy. They will sometimes need to get a bone marrow transplant. Chronic leukemias will be very well treated with sometimes oral therapy or a combination of oral and intravenous therapy. And there's been tremendous progress in the treatment of CLL, chronic lymphocytic leukemia, over the past 10 years, where the treatment landscape has completely transformed, and we have a lot of excellent targeted agents that are highly effective. So patients who get this diagnosis now have an excellent outcome with therapy.
We only have a couple minutes left in the shows to tell our viewers briefly about multiple myeloma, how it presents, and what your treatment options are.
Yeah, sure. So multiple myeloma, again, is a disease of white cells, but in contrast to lymphoma and leukemia, these are plasma cells. And when people have a new diagnosis of multiple myeloma, it comes from the bone marrow, and they will typically present with symptoms that are related to involvement of the bone marrow and involvement of bone tissue. And they will sometimes have a high calcium as well, and they could sometimes have kidney failure. Multiple myeloma is typically treated, again, with different forms of chemotherapy, but they're a lot different to the chemotherapy treatments that we use for the other blood cancers. There are a lot of other agents that are highly effective in multiple myeloma as well. There's a drug, for example, called lenalidomide, which is an immunomodulatory agent that's very effective in multiple myeloma. And there are some others as well. And just like lymphoma, we're starting to use bispecific antibodies and CAR T cells in multiple myeloma. And over the last year, actually, there really has been a lot of success in using these. So again, 20 years ago, it was very difficult to treat multiple myeloma. It was associated with a very poor outcome, but treatments have completely transformed. So our hope is moving forward that when people get this diagnosis, they will do much, much better than they did in the past.
How encouraging. Dr. Dunleavy, I want to thank you for an excellent interview. My thanks to the team here at the studio for making this show possible. And finally, my thanks to you, the viewer, for joining us this evening. If you have any questions or comments, you can reach me at the website posted below on this screen. As for our next show, I'll be interviewing Dr. Brent Berger, President of the Montgomery County Medical Society, and we will, of course, be discussing Montgomery County health issues in general. It's going to be an interesting show. See you then next time for another edition of Housecall. Good evening.